burst everything, and by 8 o'clock is there. And I said minimum presenter is enough, is enough like that. So if you make that habit, you good. Some people may join like that, and see finally what happens is you are waiting for some meeting. Finally the academic sessions will stop because that man will not come, this man will not come like that. So better you please come 5 minutes before all of you, so that the coordinator can start at 2 o'clock. Maximum 5 minutes. Somebody said, sir, you have to do some emails like that. I said, for you it is 5 minutes, for that him 10 minutes, for her 13 minutes of it. So there should be. Other system is also there. So you start the session and all people have come. It may be 2:30, 2 o'clock and 4 o'clock. So you want which one?
DG sir, Nageshwar Rao sir, and I welcome Director C.V. Rao sir. I welcome all the staff, senior and junior residents for today's afternoon program of clinical case discussion of interesting cases. So we have total of 4 cases today. The first case, striatocapsular syndrome from Department of Neurology, morphological clues for an unyielding anemia from Department of Pathology, TB pericardial effusion from Department of Cardiology and Medicine, beyond TB, an unexpected companion from Department of Pulmonary Medicine. So we will proceed with the first case, striatocapsular syndrome from Department of Urology, presented by Dr. G. Raju, Junior Resident General Medicine. The session will be moderated by Dr. Krishna, Urologist.
I'm Raju, Medicine Resident, presenting an interesting case from Department of Neurology, case of striatocapsular syndrome. The patient of obstructive neurology came to hospital with complaints of behavioral changes in 4 days, deviation of mouth towards left side since 3 days. Patient was apparently normal 4 days back and presenting complaints started as attendants noticed a change in behavior in the form of reduced interaction, poor attention, and inappropriate response. There is no history of fever, serious headache, head injury, or substance intake. Complaint of sudden slurring of speech and deviation of towards left side since 3 days. No complaints of weakness of upper limb or lower limbs, no lengthy movement, unbite, and frothing around mouth. No complaint of headache, nausea, vomiting. No complaint of shortness of breath, cough, wheeze. No complaint of chest pain, palpitation, abdominal pain, nostrils, and no complaint of decreased urinary. Past history: patient is diabetic since 20 years on tablet Greenfield, metformin, digoxin, and pathology. Patient is long as of hypertension since 20 years, using tablet telmisartan, 40 mg, 24 pathology. Not a known cause of hypothyroid, coronary disease, severe bronchoasthma. Personal history: patient is non-alcoholic, non-smoker, non-sleep, normal sleep and appetite, mixed diet, and normal bowel pattern movements. No food, drug, and environmental allergies. Patient is conscious, general examination. Patient is conscious, tolerant, well-oriented, time-based person, moderate built knowledge. BMI is 28. No brother, no interest, no sciences, no clubbing, no infertility, no pedidemia. Vitals of presentation are normal. PVP is 130/80, pulse rate 90 beats per minute. Respiratory rate is 20 cycles per minute. SPF 99% of the room rate. GLP is 490 mg per deciliter. Systemic examination: cardiovascular is S1 to present, no mamas heard. Respiratory, bilateral normal response present. GIT soft and non-tender. Power is heard. CNS examination: patient is right-handed and environmental functions are intact. Patient is conscious, tolerant, well-oriented, average person. Recent immediate and remote monitor intact. Score was 24/30. Speech is present at the time of examination. Cranial examination: first cranial is normal, second cranial examination normal, 346 cranial examination is normal, fifth cranial is normal, and seventh cranial shows right human facial palsy. 8, 9, 10, 11, 12 cranials are normal. Motor system examination shows normal attitude, bilateral symmetrical bulk, tone is bilateral symmetrical, supervision and deep reflex are within normal limits. Central system is examination is normal, cerebral examination is normal, no meningeal signs, no spinal canal difference present. Provisional diagnosis is severe acute ischemic stroke, known as the diabetic and diabetes. ECG is a always standard ECG showing the rate of 90 beats per minute. The BPC is present in the area from the area. Just examine.
Motion article stamping is ready to the visualized extent of athletes appears clear. Both nodes of the diaphragm and CP appears clear.
To recover the patient was no reading on motion target with G of 60% and mild quantity calories.
Left corona radiata extending to left mid of caudal case and putamen and the greatest area of anterior capsule, anterior limb of internal capsule. Next. And in the corresponding T2 images, we can see that there is hyperintensities in the left corona radiata and left head of caudal case and putamen, suggestive of uploading. Showing it is T2 flare showing acute infarct in head of caudal case and putamen on left side. In MRI, we can see that there is loss of flow rate enhancement on the right side in IC, in internal carotid artery, and right MC is new.
More balance cerebral system. Epidemic content in the right end of cerebral no office thoracic and waveform, complete conscious of right end of neurology. Left end of cerebral shows multiple plaques. In investigations, complete blood picture is suggested for normal blood picture. Lipid profile is normal limit. Electrolytes are the normal limit. HbA1c is 11.4, suggested for uncontrolled diabetes. LFT is normal limit. CV shows protein numbers and glucose levels. Treatment given was ibuprofen with multivitamin supplementation. Aspirin of frequency, Parvol 24 hourly. Statin 40 mg 24 hourly. Telmisartan 40 mg 24 hourly. Regular insulin of around 6 units morning and 40 units evening. And multivitamin supplementation. Final diagnosis is CVA, acute ischemic stroke, left carpal tunnel region and cardiac nucleus. Involving lateral side artery stroke. Risk factors diabetes and hypertension. In this case, this patient is hypertensive of diabetes can complaints of behavioral changes. It usually occurs in ACI supplying the anterior limb of the capsule, which is the artery is recurrent artery of the usual artery is the recurrent artery of the but in this case, the MRI is showing the reticular statement is a mass of metacellular artery. Hence, in this case, metacellular artery stroke also can present as present with behavioral changes. Difference between ACI and MCI stroke. Behavioral and executive dysfunction are very present in cranial artery stroke, whereas ventricular side stroke shows pure motor sensory hemiparesis, which is not present in this case. Thank you.
There is a classical description. What you have written is like
over attention, interaction.
Yeah.
So,
patient not responding to a lack of spontaneous response to like an activity or stimulus, prolonged latency to stimulus, or reduced ability to perform activities is called ebulia. In this patient, he classically presented like a ebulia-like pattern. So when ebulia is there, stroke in the differential diagnosis, because in this patient he is having like uncontrolled diabetes and vascular risk factors. But of course there are other differential diagnoses like patients and fever, infection could also cause the same symptoms, or any inflammatory diseases could also have the same presentation. So based on the ebulia-like presentation, so ebulia would occur from lesions from frontal to subfractal circuits, anywhere from frontal, basal ganglia, thalamic circuits. So this patient ebulia is there. We did MRI. Initially, like we thought of it's in classical ACL, like hypnosis stroke. But in this patient, there is no weakness. Still, we can't explain why there is no. Anterior limb of the capsule is involved. I'm not sure why in this patient there is no weakness. That's the beauty of this case. Even though when his presentation is like an hypnosis stroke, imaging wise it looks like it's an lateral side kind of MCS stroke. It's an hypnosis presentation, imaging wise it's an MCS stroke. Sir, can you explain there is an cantilever gap is involved in this patient, sir? This Sandeep.
This overlap in the imaging wise also. The head of the cardiac nucleus usually supplied by ACI branches, that is medial reticulocyte branches. But medial reticulocyte branch usually doesn't go to the foramen, that is lateral reticulocyte branches, which is M1 branch. This is a relative sparing recurrent artery of Hooker usually we consider when the anterior capsule is also involved. Here it is looking sparing. Probably that is the reason madam is asking that motor symptoms are less in this case, because of the general impact go to the anterior important capsule is spared. This overlap of the territory between medial reticulocyte and lateral reticulocyte is pretty much common. So this is involving 2/3 of lateral reticulocyte and 1/3 medial reticulocyte, which is the
on imaging at a different capsule. But in what so can you explain normally the lateral striate artery will also supply that anterior lymphadenopathy capsule also. In MCA strokes we see the weakness pattern more of a motor predominant, and followed by it can have the same manifestations also, like embolic pattern will also be there. Motor predominant, but in this case there is a peculiarity. Sandeep is point, there might be an overlap in
differential diagnosis based on the history. Acute onset behavioral symptoms. You have considered stroke as the first diagnosis. So it's almost like a psychiatric case. It's not like weakness or no speech abnormality, no weakness, no cranial outages. Any psychiatric, what is the differential diagnosis clinically? That's what we wanted to ask. Is it acute onset psychiatric syndrome? Like consider that or not?
This patient, if you see clear, grade 2 to 3 severe.
That is after MRI. I'm telling you before MRI. Clinical. Acute onset psychiatric illnesses.
This patient is straightforward, but as sir pointed out, it could be another causes like infections, all the diseases which involve like metabolic thing, even high sugars, like hyponatremia, all this can have a differentials based on history wise, like metabolic, infectious, inflammatory, all this should be considered in clinical exam. But in this patient, there is like in facial palsy there with uncontrolled diabetes during the scan. Sir, any question?
Stroke and thrombolysis was started in cerebral infarct only 50 years back. But the side effect was there is a reperfusion, then is more cerebral edema and more increase in the stroke like that. They stopped it. The idea was taken by cardiologists after doing angiogram. We found that clot is the primary cause. So then we started thrombolysis, and it took nearly 40 years or 50 years to stabilize. Still in India, a lot of people are not getting thrombolysis very early or recognition. So stroke also recognition is there. There are simple mnemonics have been given. I saw in metro of Toronto, in the train they put a simple thing like that. Raise your hands, talk, respond. Then one more thing is speech, slur. Immediately you call the ambulance 911 or some that number, and within half an hour or 10 minutes they will be there, and then you immediately do thrombolysis, or if necessary, if your facilities are there, thrombectomy can be done like that. So in that way, stroke should be known more for the people who are practitioners or the patients itself. Now after they are so much of advances after 40-50 years, only 30 to 40% people only come in time with acute MI, especially for our this one like that. So remaining 40 to 50% still we are losing them. They come after 2 days, 3 days, then we can't do much for them, just we do. But some relief is there like that. So, and that's why I tell that the cardiologist should be known more to the general doctor, students, or RMPs or like that, rather than once he comes to the hospital, we do angio plus all those things. But coming to the hospital, same thing, stroke should be given simple mnemonics and educate all the people. And so that's why, like basic doctors, and it may be an RMP or thing like that. He is the first person who is seeing the patient. If he knows that, he will send it to the patient like that. So it takes a long time. Another 20-30 years it may take. Then people get thrombolysis or thrombectomy for stroke people, especially in our part of it. What Vamshi? What do you think? See, stroke recognition should be done by basic people and even people educated like that. So that's why just train everything is there. Whenever on occasion I educate nurses, technicians, common people. When I came to pharmacy, that lady was asking, then immediately I told her, these are the 3 symptoms. If you have any of these 3 symptoms, immediately consult the doctor and like that. So for a recognition MI, see any, it may be pain, burning sensation, or anything like that. If you feel that it lasts you for more than half an hour, first time in our life, people never felt that type of symptom before, always MI. Then you have to start all those things. So anyhow, it may be burning or discomfort or pain or some heaviness, whatever, from neck to the upper abdomen. You ask one question. Did I have sometimes? No, it is first time in life is always MI. So like that, stroke also, they should be educated the people. If you have some speech disturbance or you are not able to raise your hands or legs, immediately consult the doctor.
Weakness or any speech disturbances. A means arm weakness. S means like in speech disturbances. And deviation of the face, like if any patient is having like a sudden onset of deviation of the face, or any arm weakness or any speech disturbances, we should rush to in hospital so that we can get the appropriate treatment. But of course, such type of presentation is very difficult to differentiate because these patients having more of a psychological symptom. These are very uncommon strokes. We don't see such patients frequently. Most common what we see is like a motor weakness or any speech disturbances.
As soon as the stroke comes, half an hour, you do just preliminary screening, blood sugar, blood pressure, everything like that. Get a CT done. Don't go for MRI. MRI may not show. CT is also mainly to rule out bleed. So only if there is no bleed, treat like ischemic stroke and then go on. So don't wait for MRI to be positive or like that. CT immediately within half an hour you do it. And CT also, I said, not for diagnosis. You may not pick up the inform. It rules out bleed. Bleed can be immediately made out. If bleed is not there, clinical is there, good thrombolysis.
Suddenly it gets not well. Everybody thought he's done some sin, so God gave and hit him until he collapsed. There is more than beauty. Have a good father or have a good mom. Why did we say we are not having art? There is art. This is only one which function is we are continuing. Because long time ago, this stuff can be held on. Word. We have to call the same correct. Good cause.
This case of presentation is morphological clues for an unyielding anemia from Department of Pathology, presented by Dr. Balasirisha, Junior Resident, Moderator Dr. Pranit K.
Hello everyone, myself Sirisha, presenting morphological clues for an interesting case of unyielding anemia. My moderator Pranit Sir, Assistant Professor from the Department of Pathology. A 64-year-old man presented to Dr.Pinnamaneni SIMS&RF with chief complaint of shortness of breath since 1 year, which is increasing from last 10 days, associated with orthopnea, paroxysmal nocturnal dyspnea, and fatiguability. Generalized edema since 10 days, initially started as pedal edema, progressed to puffiness of face and abdominal distension. No history of chest pain, palpitations, fever, cough with expectoration, vomiting, loose stools, abdominal pain, and decreased urine output. Past history: known case of type 2 diabetes since 5 years on glimepiride 2 mg and metformin 500 mg. Known case of hypothyroid since 3 months on Tylenol 150 mg. Not a known case of CKD, CAD, and hypertension. History of 10 blood transfusions done in the duration of 1 year. Personal history: known alcoholic and smoker 5 years back. History of tobacco chewing present, takes mixed diet, sleep and appetite decrease. Surgical and family history insignificant. General examination, parallel present, and sarcoplasm. Vital at the time of admission were stable. Systemic examination, no abnormalities detected. Provisional diagnosis was anasarca under evaluation, severe anemia with heart failure. Investigations done at the time of admission were hemogram. Its hemoglobin levels were 4.1 on admission. Total counts were 2,900. Platelets were adequate. Upon multiple transfusions, increased to 7%. Peripheral smear shows predominantly normocytic population with 30% of microcytes and occasional macrocytes noted. Also noted are teardrop cells, erythrocytes, and echinocytes and holocytes. WBC count was decreased, platelets were adequate, impression was given as bicytopenia, reticulocyte count was 2%. Liver function test and renal function test were within normal limits. Stool blood was negative. Coagulation profile was normal. Viral markers non-reactive. Complete urine examination shows protein 1 plus positive. Protein by creatinine ratio, protein spot urine 40 mg per dl, which is slightly elevated. Electrolytes were within normal range. Iron profile: serum iron 200, which is slightly elevated. Serum ferritin 1000, which is increased. Vitamin B12 also more than 2000 increased. Based on bone marrow aspiration was requested and bone marrow aspiration revealed hypercellular marrow with increased marrow to fat ratio, and we can see numerous number of megakaryocytes of various shapes and sizes. On higher magnification, we can notice erythroid hyperplasia with dyserythropoiesis, decreased number of myeloid cells. Here we can notice megaloblastic maturation with the nuclear seeding. Myeloid and erythroid ratio reversal is noted with increased erythroid hyperplasia and decreased myeloid cells. Plasm.
See, before going to your other slides, I just have a doubt because the patient on peripheral smear is having microcytes. How do you explain megaloblastic and you have microcytes? How do you explain microcytes or macrocytes?
In myelodysplastic syndrome, we can have microcytes.
I'm not talking MDS, I'm talking about megaloblastic.
Megaloblastic can have.
Based on the peripheral smear, what is your definitions? Because patient is having microcytes, macrocytes. What are the things? Because the patient is having bicytopenia. What is your inference based on that? Microcytes, macrocytes. Does it give any influence for it?
In MDS, we can have both, sir. In megaloblastic anemia, only macrocytes.
Population, sir. So there was a mixture of population, and when we were scanned, majority of the cells were normal, followed by micro and macros. So it is not a clear-cut, predominantly megaloblastic picture with basophilic stipulin or macrocytes. So there is a mixture of multiple patterns there. And there is some amount of ineffective erythropoiesis also. Most of the cells are not completely normocytic, normochromic also. There is some bit of hypochromasia also. So we felt like on peripheral smear based on the cytopenias, there was definite ineffective erythropoiesis. But it is not exactly pointing towards definitely saying that it is a nutritional anemia or it is a single iron deficiency anemia. Therefore, overall peripheral smear impression was given as bicytopenia only with a dimorphic population of red cells. And on top of that, the retic was also 2% and taken the hematocrit. it is absolute counts are low and the marrow proliferation index is also quite low. So till smear and retic, that was our inference, but till that time we didn't look at the marrow. So our peripheral smear impression was only bicyclic.
First time was done, which shows ring syndrome. More than 5 to 6 granules arranged perimetrially. First time shows ring sideroblasts with more than 5 to 6 granules arranged perimetrially, which indicates highly loaded mitochondria. Based on morphology, according to WHO classification, myelodysplastic neoplasm with ring sidroblast and multilineage dysplasia. According to FAB classification, refractory anemia with ring sidroblast. Coming to discussion, myelodysplastic syndromes are clonal hematopoietic stem cell disorders. They are characterized by cytopenia, dysplasia in one or more of the major myeloid cell lines. The hallmark of this syndrome is ineffective hematopoiesis with resultant cytopenias. Incidence was 3 to 4% per 1 lakh population. Clinical features present with symptoms pertaining to anemia, neutropenia, thrombocytopenia. Spleen is palpable in 15 to 25% of cases. FAB classification, it includes 6 categories. Our case fit into second category, refractory anemia with ring sideroblast. According to WHO classification, recently classified according to the genetic abnormalities and based on morphology. According to genetic abnormalities, classified into MDS with low blast and 5q deletion, MDS with low blast and SF3B1 mutation, MDS with biallelic TP53 inactivation. MDS morphologically classified into 3 classes: MDS with low blast, MDS hypoplastic, MDS with increased blast. Our case we fit it to MDS with low blast, which shows a less than 5% blast in bone marrow and less than 2% blast in peripheral blood. International prognostic scoring system for myelodysplastic syndrome were categorized into 4 categories based on the blast percentage, karyotype and cytopenias, and the median overall survival is assessed.
We'll move on to the next case, TB pericardial effusion from Department of Cardiology and Medicine, presented by Dr. Girija, Cardiology Senior Resident, and Dr. V.S. Hamsi, Medicine Junior Resident. Session will be moderated by Dr. Sampath Kumar.
Good afternoon everyone. Myself I am Hamsi, third year junior resident in Department of General Medicine. A 43-year-old female presented to emergency with chief complaints of bilateral lower limb swelling since 10 days, shortness of breath since 4 days. History of presenting illness. Complaints of bilateral lower limb swelling since 10 days, which is gradual in onset, progressive, no duration variation, no activating factors, relieved on limb elevation. Patient presented with complaints of shortness of breath since 4 days, gradual in onset, which progressed from grade 2 to grade 3, not associated with PNV, orthopnea, not associated with chest pain, palpitation. No complaints of fever, cough, cold, no complaints of headache and reading sensation. No complaints of vomiting, loose stools, pain abdomen, no complaints of involuntary movements or altered mental status, no complaints of burning micturition and change in frequency of micturition. Past history: she is a known case of diabetic since 15 years on medication on tablet metformin 500 mg by BD. Known case of hypertension since 3 years on medication tablets independent NMG. Not a known case of chronic liver disease, CKD, CAD, seizures and ED. Menstrual history: history of hysterectomy 15 years back. Personal history: takes mixed diet, decreased sleep and appetite, regular bowel and bladder habits. Family history insignificant. General examination: patient is conscious, coherent and oriented, moderately built and nourished. BMI 17.4 kg per meter square. Pallor present, no interest, no cyanosis, no clubbing, no lymphadenopathy, edema of bilateral grade 2 and peaking type. Polymeria present and venous arm is present. Vitals at the time of the presentation: temperature is ephemeral, BP is 130/70, pulse rate is 86 beat per minute, respiratory rate is 20 count per minute, saturation is 95%, GRBC is 162. serious JVP elevator 10 centimeters, no precordial bulge, apex peak left with intercostal space, S1 S2 birth, no murmurs, per abdomen soft, non-tender, no abdominopelvic bowel sounds heard. Serious GCS is A4, V5, and 6 bilateral people's normal cells reacting to light, bilateral plantar flexor, per abdomen this is a standard Valli ECG showing normal sinus rhythm.
This is a four-digit radiograph. Trachea is in midline. There is smooth symmetrical globular enlargement of cardiac shadow. Could be pericardial effusion. Prominent bronchovascular markings noted. Left dome of diaphragm and left C3 angle are upstream. Right dome of diaphragm and right posterior mechanics are free.
I got it.
Okay. There are 3-4 conditions that come to the mind here, clinician or the radiologist. One is Epstein's anomaly, congenital heart disease, or multivalent disease. If the patient has mitral, aortic, tricuspid, all those things, then they have a very big heart like that. Third one is cardiomyopathy, and first one is pericardial effusion. So these 4 conditions should come into mind, and from X-ray itself, you can differentiate whether it's a valvular problem or a cardiomyopathy or Epstein like that. Epstein is unlikely. The Epstein, you have a stencil-like cardiac silhouette. That means that just like an artist drawn a line like that, you can see the cardiac part, right bar, left bar like that. So it's not there. So then multivalvular, you have pulmonary venous arterial hypertension like that. And pericardial effusion, clear lung fields with a globular heart. So cardiomyopathy also, you have some signs of pulmonary venous and arterial hypertension. So that's why this patient, you don't see any pulmonary venous or high arterial hypertension and a globular heart. So probably it is a pericardial effusion.
Hepatomegaly grade 1 cantilever changes, contractile valvular with mild thickened valvular. CVP, HP 6.8, counts are elevated 13,900. Impressions of microcytic hypochromic anemia. RFT is within normal limits and her electrolytes are also within normal limits. LFT is within normal limits. Ferritin is 15.62, which is normal. Iron is 10.03, low iron. Vitamin D is 25.9. SOPT was negative for 3 samples. Reticulocyte count is 2 and her RPI is 1, which indicates hypoproliferative anemia. HbA1c is 9.7. TSH is 1.50. Provisional diagnosis: severe iron deficiency anemia with known case of type 2 DM and hypertension. Plan for treatment: plan PRBC transfusion, albendazole 400 mg per oral OD, Orofer XT per oral OD, lipid energy OD, sitagliptin plus metformin and actrapid. Tablet vitamin D 60,000 units once a week for 8 weeks. On day 2, post transfusion her HB was 7.8. And after 2 transfusion her HB was 8.6. 2D echo shows no LV RWMA, good systolic function, large circumferential pericardial effusion, anterior 1.8 cm, posterior 2.94 cm, lateral 2.7 cm, 18% variation in mitral inflow with respiration, 20% variation in tricuspid inflow with respiration, lateral E prime is 5.25 cm per second, septal E prime is 6.2 cm per second, IVC is mid-dilated 1.9 cm and less than 50% collapsing. No clot or resuscitation, no RV dysfunction. Patient was planned for pericardial synthesis. Then patient was transferred to cardiology for further management.
Transferred to cardiology in the view of pericardial effusion for pericardial synthesis. On examination, pulse rate was 90 beats per minute with regular rhythm, low volume and all peripheral pulses fell. Blood pressure 130 by 100 mm mercury in both upper limbs. Measured in supine position. Respiratory rate was 28 cycles per minute. Saturation was 98% on lumen and density is raised. On general examination, patient has pallor and pleural edema. Systemic examination, first and second heart sounds heard, muffled, no murmurs and no pericardial rupture. ECG, this is a 12-lead standardized ECG of rate about 90 beats per minute, regular, normal axis and no SVT changes. Echo on day 1, it is no RWMA, good LV systolic function with large circumferential pericardial effusion measuring about
1.85 centimeters in the anterior and 2.94 centimeters posterior and lateral 2.74 centimeters. There is 18% variation in the mitral inflow with respiration and 20% variation in tricuspid inflow with respiration. Lateral E prime of 6.2 centimeters per second and septal E prime of 5.2. IVC appears mild dilated and less than 50% collapsing with no clots of vegetation and no artery dysfunction.
Yes, pericardial effusion. So if you see a pericardial effusion only in systole, that means when systole contract, there's a potential space, fluid is there, it's very minimal, 100 or 200 ml like that. When you see clearly whether inspiration or expiration, nearly 500 ml, and if it's more than 1 centimeter means it's nearly a 500 to 1000 ml. So here it is 1.8 to 2 centimeters means more than 1000 ml of fluid is there. So if the echocardiogram or ultrasound, you can make out how much is the pericardial effusion, whether it's a mild effusion or a significant effusion.
Echo in the parasternal long axis view, where we can see pericardial effusion in the posterior side as well as in the anterior side. This is the apical four-chamber view where we can see the circumferential pericardial effusion around the heart. Chest X-ray PLT. This is a globular heart showing pericardial effusion. Coming to the investigations, CBP, on day 1, patient has 8.6 gram percentage hemoglobin, where there is a drop in HbA2/6 on the day 2. So we have taken a general medicine consultation for this. Then RFTs and electrolytes were normal throughout the period of admission. LFTs were normal. Thyroid profile was normal. Mantis was negative. Coming to ANA profile also negative. Provisional diagnosis: large pericardial effusion by extrapulmonary tuberculosis with good LV function in sinus rhythm and not in CHF. Risk factors are hypertension, diabetes, severe anemia, and moderate non-proliferative diabetic retinopathy. Status post 2-unit blood transfusion done and plan for pericardial synthesis. On day 1 itself, 2 liters of hemorrhagic pericardial fluid was drained with a peptide catheter. Total of 2800 ml of pericardial fluid was drained over a period of 2 weeks. This is the X-ray post peptide catheterization in the pericardial cavity. Pericardial fluid analysis: cell count is 2050 cells per cc, lymphocytic predominant and RBC present, LDH elevated of 829.4 units per liter, ADH 28, protein and sugar are also raised. Protein is 6.43 and sugar is 233. Cytology showed reactive effusion, whereas AFP gram stain culture sensitivity CBNA turned out to be negative, and hemoglobin in the pericardial fluid was 3 gram per cent.
These are the local images of the pericardial fluid segments showing sparse inflammatory infiltrate.
5 gram IV 12th hourly, Pant of 40 mg 24th hourly, tablet Ferizon 30 mg 24th hourly, IV fluids, Dolo 650 mg PID. Colchicine was started 0.5 mg per oral 24th hourly and Actapid was given according to the GRS. Treatment on day 2, general medicine opinion was taken as there was a fall in the hemoglobin from 8 to 6 in the view of anemia. They advised ARBC transfusion to start ATP and injection dexamethasone 4 mg IV 24th hourly to send for peripheral blood smear and fundoscopy to look for any hemorrhages. So we continued the same treatment and added on ATP and dexamethasone. Ophthalmologist opinion taken on fundoscopic examination. Both eyes had moderate non-proliferative diabetic retinopathy of grade 1 and grade 1 hypertensive retinopathy. So all the from day 1 to day 9 same treatment was continued and the daily drain was measured. So on day 9 of peptide catheter institute, we have converted steroid to tablet dose. So continued ADT, HIZD 4 tablets 24th hourly, then prednisone 20 mg 24th hourly, colchicine, Actapid was given 20 units, 16 and 12 units, Bezalog was added and histamine tablet. tablet Ferizon 30 mg 24th hourly and Pantoprazole. So the next day we have seen the echo. There was no RWMA, good LV function with mild concentric LVH, no MRPR and with mild PRPH, grade 1 left ventricular diastolic dysfunction with pericardial effusion still present, and anterior it is measuring 1.1 centimeter, lateral 0.8 centimeter, and the posterior it is 2.5 centimeter. CTBS opinion was taken in the view of continuous pain and sir advised pericardiectomy. Coming to the patient was taken to the pericardiectomy. Intra-op findings, there was thickened anterior pericardium, an anti-fibrous pericardium and visceral pericardium with flimsy fibrinous organized clots. Pericardial cavity obliterated with organized and resolving clots. These are the images, intra-op images showing the thickened anterior pericardium. Procedure: excision of the anterior pericardium was done with removal of fibrous layer over the visceral pericardium done, removal of clots, organized clots in the pericardial cavity done, and lavage given. Hemostasis achieved, one vein left in the mediastinum with sternum and skin closed. Post-op vitals, patient was maintained on mechanical ventilator with pulse rate of about 112 beats per minute, blood pressure 100 by 80 mm mercury. First and second heart sounds heard, and respiratory system bilateral vesicular blood sounds heard. 2D echo post-operatively, status post pericardiectomy, mild concentric LVH with no RWMA and good LV systolic function, and there is no pericardial effusion, clot, or vegetations. This is the video, post-op video showing no pericardial effusion in the PAX view. This is the apical four-chamber view showing no pericardial effusion. Chest X-ray post-operatively. Before we had a globular heart here, and now we can see the heart is also normal in size with sternotomy sutures present. Biopsy of the pericardium was sent. Excision biopsy of the pericardium was sent, and which revealed areas of hemorrhage with fibrinoid necrotic material along with granulation tissue, and marked the fibroblastic proliferation with intervening chronic inflammatory cell collections without any evidence of granulomas or malignancy.
Excision biopsy of pericardial tissue was sent for histopathological examination. This is a low power view of an HNV stain section, so showing areas of hemorrhage along with fibroblastic proliferation and fibrinoid necrotic material. Next. Along with chronic lymphocytic cell collection seen, so there is no evidence of any granulomas or malignancies in the material study.
So why means this patient had a hemorrhagic effusion, and in Indian setup and with the rise ESR, all those things, and he had a other sites of foci tuberculosis also there. So most of the time in Indian setup, a patient who has an effusion in the middle age or like that, always tuberculosis should exclude it, and we do generally treat with anti-tuberculosis therapy, and many of them improve like that. So here our resident was asked me, sir, it is not showing any granulomas, caseating or non-caseating like that. Then I said, no, you may not have, and that depends on which DT is examined, all those things. But most probably it is difficult. You cannot explain with any other infection such a type of severe effusion that we hemorrhagic and which requires surgery. So we treated and will continue for it will be going better for Malaris. How many months or weeks?
Total 6 months.
6 months treatment of anti-tuberculosis therapy, and then we'll follow up. Now she is better, and actually it was a patient from medicine, and Dr. Ishwar used to look after, and the hemoglobin was 5 grams, massive, and we tried for nearly 1 week aspiration. Every day 300 to 400 ml was coming. Then we thought, and we took the opinion of our Dr. there.
Actually, I don't know really patient is able to pericardium.
No, sir.
Responding to the, not responding to the drainage. there is an obliteration of pericardic artery, loss of the anatomy of pericardic artery. So we don't have any option to know the pericardic. That is the thing. Important findings in this patient is hemorrhagic diffusion. There is an excessive reaction of the fibrous pericardium. It's true. But no other finding clinically sensitive to hemoptysis. So we thought because of the excessive fibrous reaction, we hemoptysis, but no gaseation materials available on the table. There is no excessive fibrosis. The constriction most probably is due to the hemorrhagic effusion and the clots. So organized clots are causing the constriction rather than the visual pericardial reaction. So there is no visual pericardial reaction. Easily remove the visual pericardium, and we are able to excise and make to pending pericardium. So we do not find much difficult. Usually in root pericardiectomy, very difficult. Certainly is really very difficult. So removing the peeling of the visual pericardium, giving the antipericardium from the iron of the one lung to other lung is very difficult. In this patient, we are able to remove the entire antipericardium and also some reaction from the visual pericardium. And there are many clots in the pericardic cavity. We are able to retrieve the clots, clear the pericardic cavity. So maybe why the hemorrhagic reaction? So is there any relation to the immunity or does the patient is absent for diabetes? So I don't think it is due to the trauma in the catheters. It's purely hemorrhagic pericardial effusion. So what was the cause of the hemorrhagic effusion? Really severe.
What is the cause of severe edema in this patient? The cause of anemia in this patient?
Then iron deficiency. But continuously after transfusion also the H1 is dropping.
Second time transfusion, after second time transfusion, there was improvement.
And ADA it's not significant. Even the chest X-ray, it does not have any pulmonary tuberculosis. MAN2 is also not reactive. So did we rule out? Yeah, definitely pericardial effusion. It is up 60 to 80% of the cases. It is definitely tuberculosis. But we have to. It usually serosanguinous, not hemorrhagic.
Hemorrhagic is most common after trauma. Hemorrhagic effusion in India is tuberculosis.
Yes.
40 years for observing. Most of hemorrhagic effusion is one of the parent reaction. See the bleeding and all those. In Indian setup, young people, middle age, effusion, hemorrhagic means always suspect tuberculosis.
First, usually TB pleural effusions, it is not hemorrhagic. Usually serosanguinous. I mean, maybe straw color fluid will be there. Usually, no sir. TB pleural effusion usually.
Just listen to me. See, the acute phase is all hemorrhagic. See, straw color will occur chronic phase of 6 months or 1 year. So, the patient is presenting like this. So, hemorrhagic effusion always is the first possibility. If there is an elderly person, you suspect some malignancy like that. Otherwise, in Indian setup, it's always tuberculosis. We treat as tuberculosis.
Yeah, we treat as tuberculosis, there is no doubt. But usually here, hemorrhagic pleural effusion is not usually hemorrhagic. It is straw color fluids are mostly.
But I'm telling you, the straw color is in the chronic tuberculosis where you have after a few months or years.
Usually extractive phase, there are stages. Usually extractive phase in the second week. When mostly the diagnosis comes, usually it is straw color fluid. I'm not telling here it is not TB, but usually
it comes after a few weeks or months.
No sir.
First few weeks
usually it will be
better you review a pathology.
Yeah, definitely.
Because these are clinical experience like that. But definitely once you see straw color, it's always tuberculosis. I'm not denying that. But stock color will appear after a few weeks, not immediately. See, inflammation should subside and it should become
hemorrhagic usually with,
it should become quiescent. Then you have all these arteries are all hemolyzed, fibrous strands will form. Then you have classical stock color with high protein.
Sir, in this patient, the history is very short, 10 days history. How do you explain that history, sir? Because the history is very short, 10 days history of.
No, they present 10 days.
Patient all that constrict to this thing. History.
Start with the chronic constriction of this patient. There is recurrent family death. So, filled with clots, organized clots, and dissolving clots. So, main issue in this patient is bleeding. Bleeding from the pericardium. So,
because we should do workup for anything, anemia, we should do proper workup. Anemia and bleeding tendency. We might miss other causes also. We should go deep into this because even though we may have a blood transfusion, there is proper history in between.
Okay, she was sent repeatedly. It was only anterior pericardial mistake. She knew us can enlighten us so that our TM students will be more knowledgeable than because. See, why only the anterior pericardium is taken out? That Srinivas will help here.
usually we remove the anti-pericardium because the anti-pericardium covers the right system. Right system, first of important thing is, first of all, you have to release the left system, the aorta, and then you have to outflow tract. Because the sudden release of the right system is provide the release gradually the IVC, SVC, right atrium, and then the left ventricle, and then the left ventricular outflow tract. Aorta. So the sequence and this usually the pericardium expanding from the pedic to fatigue. This is the landmark. Very highly identifies the pedic nerve on both the sides, and we start from the base of the diaphragm to the pedic vessels. Usually we open at the diaphragm. That is the usual spare part in the pericardium. Most of the other parts are occupied by the pericardium. So we select the diaphragm as a landmark and we open so that we can avoid the injury in the heart. Because we cannot go on pump in this patient once we injure any chamber of the heart. So most of the times, if that happens, we lose these patients on the table. So it's if you take precautions, then we safely land from the surgery. Otherwise, this is very complicated surgery. Most of the times, the IVC injuries, CC injuries. So any injury on the table, most of the times, bleeding is the common cause for the death on the table.
Actually, pericardectomy is a close surgery, but it's one of the toughest surgeries. See, because here it's okay, a few times it is a constriction. As you peel off, there is a lot of holes in the right ventricle, all those things. So you are go on to suture and it's bleeding. So many times I still remember 40 years back in age like that Gopinath will hand me. If he does, the patient does well. If the assistant professor do, invariably there is a road to straight for a long time, maintaining them like that. Finally they recover like that. So pericardectomy, you think is a close surgery, but it's a tough surgery. Coronary surgery is easier than a pericardectomy. So Dr. Srinivas has done a wonderful job. Give him an appreciation. Really, it is a, see, some of the closed surgeries like PTA exclusion, that's a closed surgery, but that's a tough surgery. You have to go from the posterior to thoracotomy, aorta, everything is very near and it's a tough surgery. Though it's a simple closed surgery, you think, okay, no, it's not an open heart like that. The open heart is safe for them because they're going in a fixed plan, everything, and what she was. So, he has done a very good job because I love this one and very nice job she was.
As a pathologist, my feedback is histopathology diagnosis is confirmatory. Wherever we see granulomas, tuberculosis granulomas, they will be consistently showing a similar morphological picture. Wherever it is brain, intestine, lungs, lymph nodes, pericardium, pleura, wherever it is. And here, as far as my knowledge is concerned, the entire pericardial tissue has been embedded. Entire tissue has been embedded from A to D sections, and it was showing mostly blood clot and fibrin clots and blood elements only, no granulomas. So hence tuberculosis is ruled out from pathology point of view. And
companion from Department of Pulmonary Medicine, presented by Dr. K. Ramya, Junior Resident, moderator Dr. Banureka Madam and Dr. Monica.
A 67-year-old man, resident of Vijayawada, came with complaints of cough with expectoration since 2 months, complaining of breathlessness since 20 days, and fever since 20 days, and chest pain since 3 days. History of present illness, complaining of cough since 2 months, insidious in onset, gradually progressive, no aggravating or relieving factors, no postural or diurnal variations, associated with scanty whitish mucoid, non-foul smelling sputum. Complaining of breathlessness since 20 days, insidious onset, gradually progressive from grade 1 to 2 MMRC, aggravated on exertion and relieved on rest, no postural or diurnal variations, associated with wheeze, no orthopnea or PND. Complaining of fever since 20 days, low grade, intermittent, associated with myalgias and not associated with vomitings or loose stools and relieved on medication. Complaining of chest pain since 3 days, right-sided, mammary area, dull aching, radiating to back, no aggravating and relieving factors. Complaining of loss of appetite since 20 days, complaining of loss of weight since 20 days, 2 kgs in 20 days. Past history, no history of similar complaints in the past, not a known case of hypertension, diabetes, CAD, CKD, CVA, old PTB or asthma or COVID-19. No history of allergic manifestations or seasonal variations, history of inhaler usage, rotacaps, sporocots since 10 days. Personal history, takes mixed diet, sleep is normal, bowel and bladder movements are regular. And he is a known smoker since 20 years, 10 cigarettes per day for 20 years. Smoking index 200 and pack years are 10. And known alcoholic since 20 years, 180 ml per day. Fisherman by occupation, family history nil significant. General physical examination, patient is conscious, coherent and cooperative, oriented to time, place and person, moderately built and nourished, and BMI 22 kg per meter square. No signs of pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. Vitals at the time of presentation, temperature is febrile, pulse rate 70 beats per minute, BP 130/60 mmHg in right arm supine position, respiratory rate 18 cycles per minute and saturation 99% at room air. Systemic examination, upper respiratory tract, nose, DNS to left side, oral cavity, dental caries present, paranasal sinuses, no tenderness. Lower respiratory tract examination, on inspection, shape of the chest is elliptical, bilaterally symmetrical, trachea appears to be in midline, chest wall movements appears to be equal on both sides, apex beat is not visible, no visible scars, sinuses or engorged veins. Palpation, all inspectory findings are confirmed, no local rise of temperature and tenderness, trachea in midline, chest wall movements equal on both sides, apical impulse, half-inch medial to mid-clavicular line in left fifth intercostal space, vocal fremitus, increased vocal resonance in right suprascapular area, supraclavicular area and infraclavicular area. And on percussion, bilateral clavicles are resonant, sternum upper two-third resonant and lower one-third dull. Indirect percussion, left side resonant node elicited in all areas and right side dull node elicited in right suprascapular area, supraclavicular area and infraclavicular area. Liver dullness elicited in right 6th intercostal space in midclavicular line, tidal percussion elicited in right 7th intercostal space in midclavicular line. Right heart border corresponds to right sternal border, left heart border corresponds to apex beat. Chronic system is left resonant and right impaired. Top space is tympanic. On auscultation, bilateral normal vesicular breath sounds and increased vocal resonance in right suprascapular area, supraclavicular area and intraclavicular area. By provisional diagnosis, right upper lobe consolidation, query pulmonary tuberculosis, query malignancy.
But your findings is also there on left side, no? How do you explain it?
Right side, left normal.
Left also you described some findings in the left.
Right suprascapular. Right.
Oh, right here, left
Right.
side. What is the left side?
Left side normal, sir, isn't
Oh,
it?
left side. Okay.
ECG at the time of presentation, it's 12 leads standard ECG, normal sinus. Chest X-ray at the time of presentation.
Density noted in the right paratracheal region along with few fibrotic strands noted. This could be any enlarged lymph node or mediastinal mass. Advised at CT workup for further evaluation.
Total count 7,200. See, RFTs are within normal limits, LFTs are within normal limits, serum electrolytes are within normal limits, sputum analysis, CBNAT negative, AFB negative, gram stain and culture sensitivity normal oropharyngeal flora. 2D echo, ectopics during the study, LVF 60%, RVSP 20 mmHg, no regional wall motion abnormalities, good LV systolic function, decreased diastolic compliance grade 1, no MR, TR, AR or PAH, IVC normal and collapsing, no PE clot or vestitions. Ultrasound, abdomen and pelvis, no significant abnormality detected. CT chest.
Showing atelectatic changes in anterior and the posterior segments of right upper lobe, and there are emphysematous changes also in the right upper lobe. Next. These are mediastinal window axial and coronal sections showing right hilar prominence, and there seems to be a soft tissue density lesion. However, the interface between this lesion and the mediastinal pad or the vessels is not seen on plain study, and this lesion is also surrounding the adjacent bronchus.
CT chest with hilar prominence, possible mediastinal extension is noted to rule out neoplastic lesion or enlarged lymph nodes secondary to infective etiology such as tuberculosis. Advised CECT.
CECT chest. Here we can see there is a soft tissue density, ill-defined soft tissue density lesion involving right hilum in the middle meatracheal region, and this is encasing the trachea, the right main pulmonary artery. Next. Here in the axial, we can see that this is encasing the right main pulmonary artery and also the upper lobe bronchus, and this is seen abutting the superior vena cava, and there are also prominent mediastinal lymph nodes.
CECT chest, ill-defined soft tissue density lesion in the right hilar region with heterogeneous enhancement, encasement of mediastinal structures to consider neoplastic lesion involving right hilar and extending to lung parenchyma. Bronchoscopy was done. Impression, right upper lobe bronchus, anterior and posterior segment, near total occlusion and rest is normal. Bronchial washings and endobronchial brushings and biopsy were collected and sent for CBNAT, cytological, microbiological and histopathological examinations. And on ball analysis, cell count right side 100 cells and left side 60 cells, and type neutrophil predominance, and there are no malignant cells, and CBNAT, it is MTB detect, Mycobacterium tuberculosis is detected and rifampicin sensitive, and BAL, AFP, KOH, grams and cultures are negative. Bronchial brushing.
The low power and high power images showing a benign looking bronchial epithelial cells, alveolar macrophages and a scant inflammatory infiltrate.
Bronchial brushings, smears and bronchial mucosal epithelial cells and few alveolar macrophages are also seen along with a sparse number of inflammatory cells. Impression negative for malignant cells.
Focused photomicrograph of HME stain section showing bronchial tissue, bronchial tissue lined by pseudostratified ciliated columnar epithelium and underlying stoma showing tumor cells arranged in sheets and nets. Next. This is the high power view showing tumor cells that are round to oval with irregular basophilic appearance with iridescent scan cytoplasm. This is the high power view showing. This is the high power view tumor cells showing molding and smudging in a fibrovascular stoma. These all features are suggestive of poorly differentiated small cell carcinoma.
Cells with large hyperchromatic irregular nuclei with scanty cytoplasm. Features are suggestive of poorly differentiated small cell carcinoma. Final diagnosis: pulmonary tuberculosis with Ball-Stevenite posture and small cell carcinoma. Discussion: the coexistence of active pulmonary TB and lung cancer poses significant diagnostic and therapeutic challenges due to overlapping symptoms and radiological findings. Adenocarcinoma is the most common lung malignancy associated with tuberculosis, followed by squamous cell carcinoma. Small cell lung carcinoma, however, is rarely reported in association with active tuberculosis. Coexistent frequently delays diagnosis and worsens the prognosis and complicates the treatment. This association between the TB and malignancy was found in about 2% of the cases, according to the study by Williams University. Pathophysiological relationship between tuberculosis and lung cancer. Tuberculosis as a risk factor for lung cancer. Chronic inflammation caused by tuberculosis, it leads to persistent cytokine release and it leads to fibrosis and scarring and DNA damage and dysplasia. These changes predispose to malignant transformation, particularly in smokers and elderly patients. Cancer-induced reactivation of tuberculosis. Lung cancer causes local bronchial obstruction, impaired mucociliary clearance, systemic and local immunosuppression, facilitating reactivation of latent TB or new infection. Shared risk factors includes smoking, malnutrition, advanced age and low socioeconomic status increase the risk of both TB and lung cancer. Diagnostic challenges: radiological overlap like consolidation, cavitation, lymphadenopathy and collapse are common to both tuberculosis and small cell lung cancer. Microbiological confirmation bias. A positive CBNAT may lead to diagnostic anchoring and delay in evaluating for malignancy. Need for tissue diagnosis. This case reinforces that microbiological proof of TB does not exclude malignancy. Thank you.
So what's your message?
Even if the yes sir, even if we diagnose tuberculosis also, we should have malignancy as a second option also. Thank you.
So tuberculosis and other things cannot exist. Is there any reason? Tuberculosis should not exist with cancer? Can. The only thing, when I joined community hospital in Baltimore, first day and second day, and we should take over exchange and all that. Too many abbreviations. So I was stunned. I didn't know. The thing is MOM, 20 ml, PO, HS, PRN. This is the order. Prescription order. Can you guess anybody? What is that? MOM, PO, HS, PRN. MOM, milk of magnesia. PO, HS, I forgot. What is HS? Right, you are right. I forgot that. Or somni, that means at night. PRN, per day rota, if necessary. So like that, because Latin, we bring the Latin words in those times. So I was bewildered and I didn't know how to overcome all these things. Then one day, one wise person said, permissible abbreviations. Entire university or entire hospital has to give. So many things I don't even know what SSB, SSC, SCA, some capsule or something. So I think let us not go in that way. There are other students, your department, your specialty, you know that. It's easy. But intern comes or somebody comes and they don't know what are all those abbreviations. Too many abbreviations. Of course, there are about 100 abbreviations. But anyhow, it's fun. I just wanted to tell what dawned on me to tell you at this hour. Thank you very much. We are learning. And please, people who participate and the faculty and the members who presented, come to my chair. Thank you.